So the cranial nerves. The cranial nerves are cool. They are awesome. Let's talk about them coming up. So, where do you suppose the cranial nerves come from? Yeah, that's right. What's big and red and eats rocks? A big red rock eater. What's the difference between roast beef and pea soup? Anybody can roast beef, okay? So, nerves, they come out of the head. They emerge from the brain, unlike spinal nerves come out of the spinal cord. There are 12 pairs, and we officially have to use Roman numerals. Remember the Romans? No, of course you don't. They were dead long before you were born. But, there are people still living in Rome. I guess those count. But Roman numerals, you 1, 2, 3, 4 is IV, just like you're going to stick something in somebody's arm. That's because 5 is V. Then 6 VI, 7 VIIs, 8 VIII, and then 9 things go crazy again because X is 10. So IX is 10 minus 1. Isn't that funny how the Romans would count? How many are there? There's 10 minus 1. Yeah, thanks. Okay, so X is 10, 11, XI, 12, XII. Now, the cell bodies are in ganglia of sensory neurons. Cranial nerves are outside the brain in ganglia. Cell bodies of motor neurons are within nuclei within the brain. Now, because they come out of the head, you're tempted probably to think of that they're part of the CNS, but they're not. They're part of the peripheral nervous system. Central nervous system is strictly brain and spinal cord. The cranial nerves are peripheral nervous system. Now, cranial nerve function is an important diagnostic tool. And in fact, I know the nursing school, first semester, you learn how to do a bedside cranial nerve exam. When my wife had her stroke, a nurse came in and did exactly that, sat by her bedside and tested her 12 cranial nerves. And my friend Jill, I followed her, stayed in close touch with her throughout all 4 semesters of nursing school. And I remember during first semester, she said, "Tom, you're right. They made us learn. We had to know the cranial nerves. You were right. We did have to know them." Just to give you some examples here, to test trochlear, note the ability of the to move each eye downward and inward. Trigeminal, so use a pin and a wisp of cotton on the face. Blink reflex, all right. Strength and action muscles of mastication, as we'll see. Abducent nerve, ability to move each eye outward. Then you can see here a facial nerve. Have the person smile, open the mouth, show the teeth, close the eyes. Taste sensations on anterior 2/3 of the tongue. Sweet, sour, salty, and bitter. Vestibulocochlear, use a tuning fork and balance, asking the person to walk a straight line. So in other words, there are a whole series of tests, and I remember my former student Jill saying that she had to learn all this stuff, and they even had to learn the names of the tests, which I don't know, the Hofstadter test and stuff like that. So they hit this pretty hard in nursing school. So let's start our tour through the cranial nerves. First one is olfactory. Olfaction means smell. So the first cranial nerve is entirely sensory. You're going to have to know for every cranial nerve whether it's sensory or motor or both. So the olfactory nerve, easy, it's entirely sensory. All it does is carry smell information to your brain. It doesn't have any motor activity, doesn't move anything, doesn't cause any secretions, nothing like that. All it does is bring smell information to the brain. So the olfactory epithelium sits right underneath the cribriform plate of the ethmoid bone. Sitting on top of the cribriform plate are the olfactory bulbs you can see in the middle part of that illustration. So what happens here is you have odorants, see little odor molecules. They come up and they go into your olfactory epithelium and they stimulate those bipolar neurons and they synapse with the olfactory bulb, and then the pathway goes onto your brain, lets you know. It's oh damn, that's dog poop. That's what happens, by the way. When you smell dog poop, it means little pieces of dog poop have gone up your nostrils and come into contact with your olfactory epithelium. Think about that the next time you smell a fart, all right? That means stuff from somebody else's intestine just went up your nose. Olfactory receptors consisting of bipolar neurons send signals from the olfactory bulbs along the olfactory tracts. So there you go, there's the pathway. So cranial nerve 1 really sits right there in the olfactory epithelium. It's the only nerve, by the way, that's directly exposed to the outside world. It has to be constantly regenerated for that reason. So Had a girl in my class a few years back who had been in a terrible fire. I mean, you could tell she'd had to have plastic surgery. She got severe burns on her head and face, and it completely destroyed her olfactory epithelium, and it was unable to regrow. She therefore completely lost her sense of smell. And you might not think, oh, that wouldn't be a big deal. She said it really just was a dramatic change in her entire life. For one thing, like food didn't taste anywhere near as good anymore. I mean, she couldn't smell perfume, didn't know when she had BO. You can't smell, you can't like sniff your armpit and go, ew, I better change this shirt. She said in so many ways, like, you can't smell popcorn on the stove. You don't know if you got a gas leak. Not having a sense of smell was pretty dramatic change in her life, she said. What happens? Impairment. How can the olfactory nerve be impaired? Well, like the fire, like I just mentioned. Head trauma, sometimes meningitis, inflammation of the meninges, and brain tumors. And interestingly, phantasmia is a cool word. That means an olfactory hallucination. It means smelling things that aren't there. Now, that first sounds kind of funny or weird, but it can be a sign of intracranial hemorrhage. It can even be an early sign of the onset of Parkinson's disease. So, like, in an assisted living facility, you got, somebody there who suddenly is like smelling strawberries all the time. Then first that might seem funny, but that actually is something maybe to pay attention to. Again, cranial nerves, incredible diagnostic tools. So the olfactory nerve, just looking there, you can see in the right side, there's the olfactory nerve, the dendrites down there in the olfactory epithelium. And then you can see them synapsing with the olfactory bulb and going down the olfactory tract. By the way, when you look at pictures like this, now that we've studied the brain, you should be able to recognize structures. I wish I had a pointer that I could use to point at them, and I can't. You'll just have to look on your own. Can you see the frontal sinus up there above the nose, that space in the bone? The sphenoid sinus back there behind the olfactory tract. All right, selaturcic and hypophyseal fossa. That's where the pituitary gland is sitting. All right, see it right there? Can you see it? Can you see the mandibular condyle fossa, the temporomandibular joint? You now know enough anatomy. You can spot all this stuff. You can look at diagrams. You can look at X-rays and know what you're seeing. See the intermediate mass of the thalamus there. See the corpus callosum. Start looking for these things when you look at diagrams. You now know a considerable amount of anatomy. Well, so moving on, cranial nerve number 2, the optic nerve. Once again, the optic nerve is completely sensory. Now, some of you are going to get that wrong on quizzes and exams. I know from experience that happens, and I don't know why. That's why I'm doing such a emphasis right now. The optic nerve does not move your eyeball. It does not cause pupil dilation. It doesn't do any motor activity. It simply brings visual information from your eye to the brain. It doesn't control anything else, right? So you have lots of cells. The retina is the very back part of the layer of your eyeball. And there are lots of cells in the retina. There are the rods and cones, the photoreceptors that actually detect the light. But then there are many more layers of cells, bipolar cells, amacrine cells, horizontal cells. And the very last cells, right at the edge of the retina, are ganglion cells. And their axons all bundle together and form the optic nerve. So literally, signals from all over your retina are all traveling along the optic nerve and then heading towards your brain. It crosses at the optic chiasm right behind your eyeball. Interestingly enough, this is kind of a backup mechanism, a sort of a survival mechanism. So axons from the medial half of each eye go to the other side. They cross at the optic chiasm, go to the other half of the brain, the other hemisphere. And then, but axons on the lateral half stay on the same side. When you think about it, that's pretty cool, because if you were to lose sight in one eye for some injury or something like that, the other eye will still be sending information to both sides of the brain, all right? Some axons from the optic tracts continue to the lateral geniculate nucleus of the thalamus. Remember, all senses except smell go through the thalamus. And then on to the primary visual cortex and the occipital lobe. Occipital lobe was the lobe of the brain responsible for interpreting vision, right? Other axons go to the superior colliculi. They synapse with the brainstem and midbrain. Remember, that's controlling eye movement, visual tracking. Like, at night, out of the corner of your eye, you see something moving in the distance. you just naturally turn your head and orient. It's like, what the hell is that thing? Oh my God, it's a chupacabra. So, yeah, so notice the information goes to a lot of places because you need visual information to do lots of. Here you see what we were talking about. There you can see the optic chiasm, and you can see the green fibers, well, for the right eye there. Well, actually, that'd be the left eye because we're looking inferiorly. You know what I mean, all right? So you can see how the green on one half stay on the same side, whereas the red cross over, and on the other eye, it's just the opposite. The green cross over and the red stay on. So, again, information from each eye goes to both sides of the brain. And once again, can you spot the structures? Can you see those mammillary bodies sitting right there under the optic chiasm? You see the substantia nigra, the eyebrows of the monkey, the red nuclei, the eyes of the monkey, the cerebral aqueduct, the mouth. Okay, on to cranial nerve 3, the oculomotor nerve. Look at the word motor, oculo, eye movement. So here is a nerve that actually does eye movement. Not cranial nerve 2, not the optic nerve, it's just vision. Cranial nerve 3 moves the eye. So it's actually a mixed nerve. It has a little bit of sensory function, but I want you to think of it as a motor nerve. It's mostly motor. That's mostly its job. And so if I ever ask you about it, I want you to tell me the oculomotor nerve is a motor nerve. It controls, there are 6 muscles that move your eye, 4 rectus and 2 obliques. It controls 4 of those. It does the superior, inferior, and medial rectus, and then also does the inferior oblique. So obviously damage to the cranial nerve 3, the oculomotor, would cause an inability to move your eyes where you want to move them, all right? And of course it could happen on just one side. So one eye might still be functioning just fine, the other one might not. It also innervates the levator palpebrae superioris. Great name. Palpebra is a technical name for your eyelid. So this is a muscle. Levator, put an E in front of that word, what do you get? Elevator. And superioris. So your palpebrae superioris is your upper eyelid, and this is the muscle that elevates your upper eyelid. So damage to the cranial nerve 3 might also result in a droopy eyelid. You wouldn't be able to lift it. And the sensory portion, which I said I don't think is very important, and I'm not stressing it at all. It has proprioceptive information. Remember just the knowledge of where your body is in space with respect to the rest of your body and so on. It sends a little bit of proprioceptive information back to the brain, back to the midbrain. But again, think of it as a motor nerve. It makes it easier for you. Continuing then with oculomotor, so there are parasympathetic fibers, part of the autonomic nervous system, that control pupil constriction and accommodation of the lens. Pupil constriction, so in other words, making that little black spot smaller. And then accommodation, so when you focus your eye on something, when you look at something off in the distance, the cornea does most of the focusing for you. The cornea is a little clear bubble on the outside of people's eyes that you can see. The lens is actually back behind the iris, the colored part of your eye. You can't see people's lenses unless they've got cataracts, and then they look cloudy, and you can see the cloudy in their eye. See that like a lot in dogs? They have those blue cloudy eyes. That's the lens. It's back behind the iris. What happens is when you look at things up close, the cornea can no longer do all the focusing. So you need extra help, and that's what the lens does. So once again, diagnostic purposes here, if you got somebody whose pupils won't constrict when you shine a bright light into their eye, or somebody who can't focus on near objects, that's potentially a sign of problems with cranial nerve number 3, the oculomotor nerve. See how incredibly diagnostic these are? So what does impairment result in? Let's look at some of the fancy terms here. Mydriasis, pupil dilation. So if you can't constrict, then your pupils are dilated. You have mydriasis. Diplopia, fancy name for double vision. If both of your eyes don't point at exactly the same thing, then your brain gets 2 different images and you see double. Strabismus is where you can't coordinate the eyes, and so one eye points in one direction, the other eye points in the other. And then ptosis is drooping of the eyelid. So again, damage to the nerve. You can't control the levator palpebrae superioris muscle, therefore your eyelid droops, okay? So here you go, model files lawsuit for botched boobs. Yeah, well, looks like the surgeon didn't do a very good job on that one. surgeon says, they look fine to me. See, that was a joke. That's just a funny little joke. That's strabismus right there. There you go. All right. If you're gonna get a boob job, don't get a surgeon with strabismus.